Welcome back to Taking Charge of My Cancer podcast, episode 54. Joining me today is Dr. Shelley DiCecco. Shelley is a physical therapist, a CLT, CISC, and she has a PhD, and she found LymphEd in 2017 as a part of the Casley-Smith International. She completed her physical therapy degree in January of 2000. She became a women's health specialist for pelvic floor disorders in 2000 and a certified lymphedema therapist in 2001. She received her PhD from Texas Women's University in the philosophy of physical therapy in 2012. Her research involved treatment techniques for females with genital lymphedema with or without lower extremity involvement. She assisted with and led several continuing education courses, conferences, and seminars, as well as present on community events of lymphedema, pelvic floor disorders, and other orthopedic conditions over the years, both nationally and internationally. She has published articles on lymphedema and pelvic floor disorders and contributed to books on lymphedema. Dr. DiCecco currently is the director of the lymphedema and pelvic floor service lines for the Sports Rehabilitation Center in Atlanta, Georgia. She specializes in the treatment of patients with genital, pediatric, or complicated lymphedema. Dr. DiCecco is also full-time faculty as an assistant professor at the Georgia campus for the Philadelphia College of Osteopathic Medicine in the Department of Physical Therapy. She focused her research on the lymphatics and lymphedema. Her current research involves cadavers, genital lymphedema, and pediatric lymphedema. She is a member of the American Physical Therapy Association and its oncology, pelvic health, and education sections. The Lymphology Association of North America, National Lymphedema Network, International Lymphedema Framework, and Casley-Smith International Group with the role of vice president. Besides work, she spent time with her husband, Rob, and her two Bengal cats. So Charlie, thank you so much for being here. That's a very impressive bio right then. So thank you for all you've been doing for this society and really helping us in the research of lymphedema. I have the pleasure to listen to your recent presentations at NLN. So it's really fascinating what you guys are doing. So that's super excited. So thank you again for that.
Thank you for having me. I appreciate this.
Absolutely. So you want to tell us about your journey a little bit? Like, did you ever thought about becoming like a pelvic health specialist and focus on lymphedema, or what happened with that path?
No, in kindergarten, when I was asked what I wanted to be, working with genitals was not coming out of my mouth back then. I don't even think I could say the word genitals really back then. That I thought I originally wanted to be a veterinarian. But then I realized I was not going to stick thermometers in animals' bottoms. So that quickly fell off the radar. I used to go with my maternal grandmother to her chemotherapy and some of her other cancer treatments with her. So that led me towards the medical path. And my parents were always very supportive. And if you were going to go after something, they wanted to make sure you really understood what you were getting into. So I was a candy striper one summer. And when I went to apply for it, the only opening on the medical floors they had was in the NICU. Mm-hmm. And a very nice lady that interviewed me said that she thought I'd be a little too talkative. I don't know how she got that, but she said I would be too talkative for the NICU. So she suggested physical therapy instead. And I loved it. That I liked how with physical therapy, you really get to see the patient through the whole process, from evaluating them through their therapy until they reach hopefully their goals, and that you form that connection. So I switched from medical to physical therapy. And then in PT school, halfway through, I was diagnosed with an autoimmune condition with rheumatoid arthritis. And I was going to a highly manual school program, and I had to meet with all the faculty to figure out, what are we going to do with Shelley? Can she practice? What's going to happen? So at that time, pelvic floor services and lymphedema were relatively new on the radar in the late 90s. So I was suggested to go into those two fields because they had, quote unquote, less manual hands-on work. Uh,
That's a good one.
yeah. So I was able to do a clinical while in school at a place in Florida that did pelvic floor and lymphedema, and I fell in love. That I liked that not only were you getting them back to, work or other activities, but you really with both got them back to more basic human needs. That a lot of the patients, especially for urinary issues, were avoiding family members and loved ones because of leakage issues or odors. And with lymphedema, they were hiding themselves because of the disfigurement and stuff. And so you really helped allow them to just participate in regular basic functions of connections with people and getting dressed and things like that. So and it also still had the cancer component to honor my grandmother. So I switched gears from thinking I wanted to be a therapist in the school system, and because I wanted my summers off. And so I switched to this, and my parents again were very supportive. They helped me go to conferences and courses to make sure that's what I wanted before I even took a job. And got hooked into that area. So my mother went to Nashville with me for a pelvic floor conference. And so she was completely overwhelmed with, oh my gosh, there's vaginas everywhere. What is this? So I started taking courses as soon as I literally graduated. And it's kind of been a roller coaster since then. And because of the two specialties, back when I went through this, there was no really topic of genital lymphedema. That most of the lymphedema was breast cancer related that you heard of and saw in the clinics. And the pelvic floor stuff was mainly pain and incontinence and constipation issues. But because of my fondness of both and specialty in both, that in Atlanta and the Southeast, they just kind of all kept coming to me. The therapists would be like, oh, you got genital involvement, go see Shelley. So that's kind of led me to become a specialist or leading the field with genital lymphedema, was because of all of these circumstances that occurred early on in my career. And it's just kind of taken off from there. So that's kind of how I got to where we are today.
That's great. That's a very fun story. The most fun conversations is what happened with pelvic floor therapists. We have a pelvic floor therapist as well. And it is so much fun when we have lunch together, mainly. The guys are so used to at this point for our conversations, so it's just so much fun. And then it is just when that door gets opened, then anything can be said about it, right? No matter what it is. We were talking about prostate cancer the other day. And then, she was just kind of explaining things. I was just like, really, it's all just the comments. It's like if somebody just walking into that conversation, they're gonna think like, what is this? Like, what are you talking about? Because people doesn't see that this is another part of the body, like your biceps and your quadriceps, and needs to be touched and needs to be treated like any other part of the body, that people is super intimidated to treat or talk about it, right? Because the whole society and the whole lack of, like, I remember when I did some pelvic floor courses as well back then. In Jacksonville, they were planning to bring like a woman's health specialty. So all the female therapists, we have the opportunity to do all these courses for free, because they're like, let's train everybody, and whoever wants to do it, continue doing it, but we'll just bring continued education to everybody. And I was totally like, oh my God, this is an anatomy that I have no idea, right? So it gets overwhelming at times. So but that was really amazing how it's such a huge part of your body, and how the influence that happen, not just with core or not just with just the actual function of the pelvic floor, but all the connections to, like, thoracic spine. I mean, it's so many things that are just so connected everywhere, coming from pelvic floor. That really amazed me, the amount of impact and really improve quality of life for these patients that you guys are able to do. So that's really amazing. So
thank you. Yeah, it can refer from ribs to big toe. So I've had patients post hysterectomies that have rib pain, And so they've gone through all kinds of testings and procedures and treatments. And so I'll be like, you know what? Shelley does this weird voodoo stuff. Just go see her. And sure enough, when you go in, and it's usually the operator intern is, when you poke on it, it just lights them up. And they're like, that's my rib pain. And so it really can wreak havoc. And then you add swelling in there from lymphedema issues. And again, it just plays in on weird symptoms, and it limits their progress with leg involvement and other components, and interferes with intimacy. That it's sad how underrepresented it is in treatment and even in books or anything like that, it's probably the Mecca center for almost every system in our body besides our cardiovascular, that everything else either starts or ends there, and we pay no attention to it really.
Yeah, absolutely. So if you can give us 3 valuable tips that you learn about your journey, and then your journey as a therapist, but as well your journey treating patients with cancer or with lymphedema due to genital cancer. So that will be a good 3 tips in both directions.
I guess one is not to be complacent, that the medical field is ever evolving, and even our patients of today are nowhere near like they were 20 years ago when I started treating. So making sure that you keep pushing yourself to learn more and to take other courses or webinars or podcasts, and like my students and family laugh, I always have articles that I'm reading or books that I have open going through them, that not to just get comfortable that I'm a therapist or I'm a whatever I am and I know what I'm doing. I don't need to learn more. I don't need to stay updated. That I think if we flipped it, would we want to go to a cardiologist for a heart problem that hasn't really gone to advanced education things since he or she graduated? That, I mean, we expect the ones we see to be up on the newest drugs and newest surgeries and everything like that. That why do lymphedema practitioners not hold themselves to that same expectation? That we should be out there, especially now since COVID, there's really no reason why you can't. That there are videos everywhere from all the different companies doing these great webinars and stuff like that, that you've got to keep pushing yourself, and you actually can get endorphins from learning. So it can actually be fun or exciting. And so that's one of my biggest pet peeves and tips is don't get complacent, keep going. That's what keeps the drive in your job. Another one's admit when you don't know and that you need help with an answer. That it's not, we can't know everything. I joke with my husband that I know everything. So I hope he doesn't listen to this to find out I'm admitting I may not know everything. But he didn't need to know that. If you don't know, that look it up. That even with my patients, I always have my computer right there, that if they start a new drug or the doctor's doing a new procedure or something, I Google it with them and we go over it. And so the patients are happy that you tried. Like one of my patients, I've had her on and off for several years. She won't start a new medication without talking to me. And it's only because I Google it, we go over the side effects, we look at other things, and I take the time with her. I don't know the drug she's starting without it, but her other physicians and medical practitioners don't take that time. So now even her primary care laughs. He's like, here, I want you to try this, but talk to Shelley and let me know what she says.
It's the trust and the time that we have to listen to them.
So, and I learned stuff that I enjoyed. I'm like, oh my gosh, I didn't know this medicine was out there and can do this. So there's nothing wrong. And I think it makes us actually seem more human and relatable when we admit, I don't know, but I'm going to find out. And next time you come in, or I will email you, I will tell you hopefully what I found out about it. That it's okay that we don't have to provide everything with treatment every single visit. Like the first time I see a patient, I don't actually typically treat them at all. Because it should take you so long to get all the way through what you need to do and what you need to explain, that
Yep.
there's not much time left
Yep.
for me. So I think it takes a stronger person to say, not sure about that, than to guess or make up an answer or downplay what they're asking.
Yep. Yep. Absolutely. Yep.
And I think the hardest thing I ever had to learn was how to say no. That I'm the third child. I always want to please people. And I remember one job, they were like, oh, can you plan this? Can you do that? Can you take care of this? Can you organize that? And I kept just saying yes to everything until while I was working on my PhD, I just couldn't. That I had to start saying no. And then it actually became an issue with that job because now I was saying no. But you have the right to say no to stuff, realizing it may not go the way you want. But if that's something you need to say no to, then say no to. So you can't wear yourself too thin and not look at that work-life balance. That I don't do emails after a certain time during the day, that's my time to decompress, to step away from my devices. I no longer feel that I have to give up all of my time to get patients in. That I wish I could, but I've got to have my own mental health. And yes, I do need to go home at this time. I can't stay 3 more hours to treat 3 more patients.
Yep. Yep.
So it's that finding that ability to say no and stick to it. Like a gentleman in our school that's actually up over my program is doing some interesting research and asked who would like to help him with his research. And I so wanted to, and I just kind of, no, Shelley, no, you have so many research projects going right now. You may not add another one. So I deleted the email immediately and did not respond.
Like that doesn't even exist.
It's gone. But I would so want to do it because this has nothing to do with anything in my practice, but I think it'd be interesting to learn about. But I had to just say no because I've got to get my other research done and published, and I don't have time to take on another project.
Yep.
So being kind to yourself and realizing it's okay.
Yep. Yep.
So
how about for patients?
Patients, it's learning to balance what you expect and what you're willing to do. That you can't, it's kind of like with me. If I want a beautiful chocolate cake, I cannot expect it to occur because I threw some ingredients in a bowl in the microwave. You're going to have to take those 3 to 4 hours to slowly put everything together to build your perfect cake.
I like that. Yeah.
So it's the same thing with your healthcare. You need to decide what you want, and then what are you willing to do and adjust accordingly. That, and I think it doesn't matter whether it's lymphedema or anything with healthcare. We all do that. We want to be able to run a marathon, but not do exercises or eat healthy. That we want to be able to wear certain clothing without wearing our compression to get us down and maintaining it. So there's a give and take. None of us like to floss or brush our teeth when we were little. Our parents had to force us, convince us, bribe us, whatever it was. But now it's second nature. I hope for most people. If it's not, please do not let me know that you do not brush your teeth. I'm hoping everyone on this listens to this is brushing their teeth. But we didn't want to. We didn't want to give up that time playing with whatever it was or watching whatever it was that we didn't want to do it. But now we don't think anything about it. So you have to take your different health aspects and kind of do the same thing. That you need to figure out what you want and what you can do to get there, and realize it's the onus is on you. That I'm going to help you with all the tools I have, but I can't do it without you.
Correct. Yep, that's a very good one. How about your most painful lesson?
Kind of goes into that you can't want for your patients more than they want, and you can't save everyone. That when I first started, I was young, and I saw, especially at that position, a lot of breast cancer and cancer-related conditions, and I just got so involved. And unfortunately, with cancer-related, especially back then, we lost more. and that it tore me up, and, trying to do stuff for their families and for them. And I'm not saying not to, care about our patients, but again, we have to realize that if they don't want to get better, or they don't want to do this part of whatever it is, we can't get them there for them. We can encourage them, we can educate them so that they know as much as possible about their condition and can make their choices, but we can't help them if they don't want to be helped. And we have to let them know that that's okay. If you're not ready for the treatment, it's okay. Come back when you are. And again, trying to make sure that still that life balance for you and for the patients, that sometimes, especially our cancer patients, from the first day, they're never allowed to say no. They're told, you have cancer. You need to see these, and these people. You need to have this, and this test. You're going to now have this surgery or this treatment, and it's a whirlwind for our cancer patients. And they never get to say no until they get to the therapist. And if they need to say no, then say no and come back in 6 weeks. Go have fun. Don't think of the C word, and just do what you need to do. And when you're mentally ready, come back. Because if you push them at that point, they usually don't do well with therapy or something else in their life gives. So giving not only your ability to say no, but giving that to the patient, that they have the right to say no, and you have to be okay with what they choose, because it is their life and not yours.
Yeah.
So that doesn't mean I don't cry anymore. I still go to funerals. I still do stuff like that, but I try to realize it's not my fault anymore.
Yeah.
That I was there. I did the best I could for them during their times, but because they did or did not succeed in therapy, it's not me that did or did not succeed. It's them.
Yeah. And I think you bring a really good point. Sometimes we get so involved with the patients that sometimes it's like, you and I know that if they don't do what we ask them to do, we are not going to be successful, right? So if they only do half of it, if they only do the manual lymphatic drainage and they don't do the compression, it's halfway through. So it's not the great outcomes we want to see. And we know that because we see it every day, right? Day in, day out. Sometimes they just look into, it's just overwhelming and I only have time for certain things. So sometimes it's make them realize, I got you. And if you want to do that, that's okay. But know that you're only going to get half of the results. And if you're okay with that, but don't expect 100% of result when you're not putting 100% of the effort, right? So it's important for sometimes I found that some of my colleagues don't talk to the patients up front like that. So the patient doesn't know what to expect, right? So sometimes I like to take that time on my first eval and be very clear about, this is what I can do for you. This is what you need to do with me for us both to be successful. Otherwise, it's not going to work. And then they choose if this is the right time, or like you say, or maybe this is not the right time. Let's wait a little bit until you resolve some conflicts or personal issues you have. And then we can go ahead and move on when you're 100% here with me, and then we can do this together and try to be as successful as possible. So I think that piece of education is super important, because we know a lot of our lymphedema patients, when they're really chronic, it's really hard for them to stick to it, right? Because they get tired, they're done, it's too hot, whatever. So it is really a hard thing to do, but they know that if they don't, it's only going to get worse, right? And so I have seen patients like they don't do it and they come and they're worse. And then they expecting us like, just make me better. And, and then this whole cycle keeps coming back again. So really it's important for us to be clear with them and them to understand. Or like you say, or sometimes we say, maybe you want this, but this is not the way it's going to be happening until you are not really committed to this. That's the way that we need to get happen. Now, if you want to go somewhere else that they're willing to do only what you want to do, that's totally okay. But just try to be as honest with your patients as possible and get them really commit to it. Otherwise, you're not going to be as successful. So,
And I think education plays into that.
mm-hmm.
That, like, if I go to a car mechanic you can name all these things you want to do to my car, but for me to pick and choose which ones I have done, I need to understand what they do to the car.
Mhm.
So the same thing, like obesity is a big issue now, that if you use the word fat or obesity, our patients kind of shut down.
Mhm.
So I've started using the formal terms and explaining, do you know what adipose tissue is? And they'll be like, no. And so explaining, well, adipose tissue are the little cells that would technically be called a fat cell, and the adipose tissue releases these chemicals, and these chemicals do these things to your body, and that's how it impacts your cardiovascular and your lymphatic system. And going through that way, and I remember it was a patient's husband, and the patient had asked me to do this because she knew she was terminal, and her husband had gotten very overweight, and she wanted him to lose weight for her, that she wanted him healthy when she passed. And so she had asked me one session, can you talk to my husband about weight? So he was a dentist. And so I was talking to her, but to him technically. And we went over what adipose tissue is and everything else. And he was so enthralled. And he was like, really, I've never heard of it that way. And And we have kept in touch over the years since she did pass. And he has, once you put it into what the chemicals do and how detrimental they are to you, he took it from that standpoint versus a size or look component. It's the health of that tissue. But most people just say you're overweight, you need to lose it. That's not true. It's not the weight. It's the cells and their chemicals that you need to lose to not have strokes, diabetes, heart attacks, or worsening of lymphedema or the development of lymphedema. That think we underplay how important educating someone is, but that also goes back to how much do you know about it? If you don't know about it, that's that complacency. You've got to make sure you are researching the topic so you can talk about it and explain it to them.
Yeah, that's a very good point. I really like that. Is there anything that you have that will be of value for our audience? And will you share it with that?
I think, especially with like genitals, I think one of the biggest issues is that everyone considers it kind of taboo. You're not supposed to show your privates. You're not supposed to talk about your privates. That's been preached upon us since we were little. As healthcare practitioners, we shouldn't think of it as our privates. It's another body part. And so if you focus more on the anatomy, the physiology, and the pathology component, just like you would for head and neck or foot or anything else like that, if you focus on that, then it's not male genitalia or female genitalia looking at you. So you've got to look past it, just like you do with everything else, as what is this? What are the structures underneath it? How do those structures perform together? What is the pathology that's now affecting these? And what do I know about physiology and pathology of how to address this? That if, the nodes are missing, what do I need to do? I need to reroute the fluid or encourage other pathways. That don't think of it as, oh my gosh, that's someone's scrotum right there. It's a body part. And the more you focus on it that way, I always tell patients, it's just like a knee to me, that I don't see sexuality with it. I don't see all these other components. I see a piece of anatomy. I know the anatomy. I know what's all supposed to happen. What can I do to address it? And don't treat it any different than if they had a huge growth on the side of their thigh. That if you're uncomfortable and you're downplaying it as you don't want to be around it or that shouldn't be discussed, then that goes towards the patient. That one of the studies a colleague of mine did out of Wales, they had a handout that they gave them, a questionnaire that had all the symptoms associated with genital lymphedema. And a lot of the comments that came from that was, I realized this obviously is something others have because it's typed on a sheet of paper. So I was more comfortable discussing it. So we need to get them discussing it. So again, it plays into that differential diagnosis, that what am I seeing and what can I do for this patient? Not going back to that childhood taboo component and helping to break the stigmatism associated with it. And as long as you look at it as another body part, you can treat it. But if you're not comfortable with it, then find someone who is. Don't treat around it. That I see too many patients where they come to me in garments for their legs. And they said, my therapist treated the legs and said, now you'll address the genitals. You treat the genitals before you treat the legs. Because I always ask, well, was it this swollen when you started there? Well, no, it's gotten worse. That's because everything just pushed up to the top of the leg and dumped into the genitals. So it's okay if you're not comfortable with it. Like, I don't do drool. I don't really love going into ICU rooms where they have to have suctioning and stuff like that. I think it's where my brothers held me down and did that little spit wad at you. So I don't like true drool coming out. So I always at the hospital was like, I'll treat any patient. They can vomit on me. They can bleed on me, whatever. I just can't take it if I have to suction them. So that's not going to be an area I go into. So know your limitations, but I know how to refer someone and recognize and diagnose and then refer them out, but don't treat around genitals that either get comfortable with it or have in your pocket who you can send those patients with genital involvement to, and don't use up their insurance visits and make it worse because you treated around the genitals.
Yep, that's a great point. That's very valuable. How can people find you? And I'm going to put all the details on the show notes, but where can they get a hold of you?
So email is the easiest. My email is my name, Shelley, Shelley, DiCecco, DICECCO at LymphEd, lymphphed.com. My website is also www.lymphed.com, so lymphphed.com. I do get a ton of emails a day, especially right now with all the sales going on. I do understand all these places have sales. They don't need to email me 12 times a day. So I get anywhere around 300 or more emails a day. So if I do not answer you, please email me again, because sometimes they get lost in all of the rigmarole of all the emails. So I'm not trying to ignore you. You're now on 3 pages back because of all the emails that came in after yours. So I'm available for consults. I don't charge for them, but if you want to run something by me or ask my advice, I've been on Zoom meetings with patients and therapists to kind of work through things that I'd rather help you get comfortable with it than to have the patient or you technically suffer from trying to treat without really comfortable with doing what you're doing.
That's very good. That's very, very great of you doing that. Not that many people do that. It's like, well, check and then it's gonna be an hour per consult. So I think this is what makes a therapist a great therapist. It's not just about what we do for money. It is about what can we do to really improve quality of life of all these patients, right? They have plenty of issues. So definitely anything that we can do to try to really improve that is just amazing. How about 3 books that you would recommend for the audience and why?
So I do like the Let's Talk Lymphedema by Peter Mortimer.
Okay.
That I think he wrote it in 2017. I like it for healthcare professionals, patients, loved ones, and I even have my physical therapy entry-level students download it. You can get it for free on the Learn website, or you can buy a hard copy on Amazon or any of the other sites. It's a good overview for someone to not get overwhelmed. And it also helps that if you're not comfortable or you haven't treated many primaries or other forms of lymphedema, it gives you an overview on those. So it's a nice kind of beginning book for people to kind of start with to see what is truly lymphedema. So I like that one. Another one that's actually back from early 2000s is called the V Book. It's it's the V Book, A Doctor's Guide to Complete Vulvovaginal Health by Dr. Elizabeth Stewart. That there's a lot of misinformation about women out there. And this book takes you from birth to death and everything that is normal and everything that is abnormal. Like I remember I even took a continuing ed class back in the early 2000s where I was told acne is not normal in the genitals, so that must be warts or something. It's skin. Just like your back, just like your face, that acne can occur in your genitals and it's not warts. So this book has some humor of how they've treated some of the things with women over the ages. but it helps all age groups realize that, is this a normal sign of menopause? Is this a normal sign of puberty? So that you realize that it's not incorrect. It's easy to read. I recommend it for all ages of women. Mothers can go over it with their daughters. If you're already an adult woman, it helps you with birthing issues all the way through menopause, because menopause has so many symptoms. Like I even asked a doctor, hey, I'm starting to get heart palpitations. Should I worry? What's going on? Could you have an idea of why maybe I'm starting to get them? And the doctor was like, no, I have no idea. Maybe you need to see a cardiologist. I Googled it once, heart palpitations at night, pops up, common sign of menopause.
It's not cardiology consult needed for
So
that.
I'm still going to see a cardiologist to be thorough, but I fit the thing exactly. That, again, don't be afraid to admit, I'm not sure, but let me Google that, Shelley, because it just pops right up. So the V book does a very good job of really explaining it. So I like that one. And then I'm a historical fiction junkie that I love reading. You need something to decompress. So I love reading historical stuff to find out about how someone did this. What did they find as herbs and stuff to use in the past? How did they color clothing? Different aspects that it still can help you with today. But it also helps broaden your horizon. And if we don't learn our past, we can't move forward correctly in our future. So like even my husband and I, he will hate to admit it, we watched the Barbie movie the other day. And they showed the actor playing the woman who developed Barbie. I was on Wikipedia the rest of the night learning more about her. How did she come up with Barbie? Why did the knowledge, learning it. So I love finding that's what I do in my downtime, or when I'm really stressed or when I'm traveling, is I have some historical fiction that I am reading, or autobiography or something. And a lot of times the historical fictions have some romance in them, but something where I can still learn, but also decompress and not always be reading a medical journal. So I would say find something that you enjoy. It's a cooking shows, whatever it is, something that encourages you and your life balance component.
Great. Now, as you mentioned, some of the things with books for patients, what will be good resources for patients to go when they want to know more about, I'm having some swelling, right? Either a genital swelling from a woman, even from a guy, on the scrotum or any of those areas, like what will be a good couple of resources for them to go look into it?
So I'd be careful on Googling.
Yes, yeah. Not Dr. Google, not a great idea. Yeah.
Yeah, so the International Lymphedema Framework, the ILF, they have a lot of publications that are free to download. And what they do, which is nice, is every couple years they update them. So in 2022 or 2021, I think it was 2021, I was part of the group that redid the genital documents. So we have updated, what is standard care worldwide kind of thing for genitals. We finished pediatrics recently. And so there's a whole thing on compression. There's children. So they keep adding and updating their information. Learn has a lot of really great webinars, and some of the other companies do too, like LymphoPress, and all of those are getting out different seminars. So you can go back and watch those videos. The Lighthouse Lymphedema Network has a lot of stuff on their site. So it's finding the bigger organizations and seeing what they have to offer and asking, hopefully your therapist can kind of help guide you in based off what it is. That I send stuff to my patients all the time of, hey, here's your doctor on a webinar, watch this. That trying to help guide them into what is right and what is not good things. Like, please, if you're listening, do not do ginger oil. It does nothing for lymphedema, but I've gotten that question so many times because it's on the internet as something that helps with lymphedema. It's the act of massaging the oil in is what helps with lymphedema. Ginger itself does nothing. So eat a ginger snap cookie and do massage if you want. But so it's trying to help them find it. But those are some good websites that won't give them false information, or at least that we know of currently is false. We may disprove it a couple years down the road.
Okay, great. Is anything, another question that you would like to share with us that, I haven't been asking to wrap up?
I guess that I do treat more than just genitals. That yes, I have become a pillar in that area where I do a lot with genitals, but I work with, the difficult to diagnose. That I teach differential diagnosis at the school. I love to find diagnoses. So I see a lot of really complicated cases trying to find what's going on. I treat head and neck. I do a lot with pediatrics. So I do know more than just genitals, but I find sometimes at conferences and other things that I'm just the genital lady. But I'm not just genitals. I am comfortable with genitals. I know a lot about them and stuff, but I also know a lot about the other aspects. So again, I'm a resource if you need questions on pediatrics or other things that you're trying to do, or you can't figure out why is this person swelling? Where could it possibly be coming from? That I could treat ortho. That I did that for several years along with my other specialties. So I am more than just a one-trick pony.
Yeah.
Not just the genital queen.
Definitely. And then actually I want to ask one last thing, and I know that thank you for your time. If you want to just give us like a little line words, little summary of your amazing research project on the lymphatics that you're doing right now.
So I have started since being at the university. One of my major research projects is working with cadavers. That a lot of what we have in our medical books, especially on the lymphatics, was done with 8 or less cadavers, and mostly they were usually male cadavers. So a lot of the pictures we have, or especially the data on lymph nodes, is limited by that. So I just published for the pelvis that my student research team and I went through over 40 cadavers and counted nodes to get closer ranges in the different regions. We've now completed, I'm waiting on the final stats for the neck, but we've done the major regions, the axilla, the pelvis, and the neck, of getting closer ranges. And my goal with that is hopefully on the physician side or surgical side is maybe get the physicians to realize these are a closer range of what truly is there. Maybe I don't need to take all of them when I'm checking to see if they have cancer. That obviously if the cancer is spread, yes, but I saw a video where the guy was just doing a biopsy to see if the patient had cancer, and they took every inguinal node. But also to help us as therapists to give more reliable expectations to our patients, that if we can get the op report and we see that they've had over 2/3 of the nodes removed from that region, they're probably not going to be as successful in treatment outcomes as someone that's only had 1/10 of the nodes removed. Okay. So helping us provide better expectations so that patients don't think we did a bad job because we didn't get them to where they wanted. Well, their damage was much more involved than someone else was, since everyone's not a candidate for surgery. And then I'm doing a lot of other research with different populations, different body builds on how it impacts. So again, that's why I say I had to start saying no on research, because I just keep doing so much. I have one that should be coming out relatively short on therapists' comfort with and knowledge on treating genitals, to really see where's the gaps and how do we like to learn. The study showed that almost everyone that answered, and there were people from all over the US, we had over 150 people, they like to learn hands-on. They want to be able to get in there and figure out on other clinicians how to wrap it, how to measure it, how to do the MLD, versus just doing visual learning on videos and stuff. So as educators, we should try to meet what they want or what they need to help move us all forward in the way we want. So a lot will be coming down the pike. So I'm excited about it. And then I can say yes to more ideas, but I've got to get several things published and out of my to-do list so that I can move on to the next ones.
Well, thank you for that, because if we know for years, a lot of the things that we did in therapy was a lot of lack of evidence. I'm so happy that we're doing more and more to try to really make the point that, all the anecdotal stuff that we've been able to say, I know this works, so I just cannot have the research to prove it. So I'm so glad that there's people out there like you that is really looking into doing all this to bring all the evidence for all the things we do. So thank you for that. So Shelley, was an amazing, fun conversation. We can continue on and on and on and on for hours. You have so much to give. And so thank you so much for doing this with me today.
Thank you so much for having me and for having this podcast for clinicians and for family and patients to listen to. So thanks for all you do for us too.
Thank you so much. So you have a happy new year and have a great evening.
Thank you. You too.
Okay, bye.